I'm Joel Mallory. I'm sort of the going out the door director of the mental health board. I'm going to see the other guy in a second. Renee Clarick from University Hospitals. Bill Russell, Home Progression Services. Hold your applause, please. Don't applaud for him. Rob Young, Town Hall 2. Senior Bridget Sons, also Town Hall 2. And let's see, Nicole Thomas from Children's Advantage. Kelly Jo Jeffries, Portage County Job and Family Services. Three of them. And Larry Lippert from Sheriff's Department. So, I don't have my slideshow here, but that's okay. The most important, well, Joe can come behind me here. So, the biggest update for the Mental Health and Recovery Board is there is a new person here. I'm still hanging around until January 4th. His name is John Garrity, and John has permission for a full year. Everything that goes wrong, it's Joel's fault, my previous director. So, John, you want to say hello to this for a second?
Thank you. Good morning, everyone. I am so excited to be here. This is my beginning my third week on the job, 12 days, and I'm just so impressed with Portage County and Mental Health and Recovery Board, but the entire county. You know, people talk about how it takes a whole community working together to combat substance abuse, and just the short time I've been on the job here, I see that is so powerful in Portage County. You know, working with the board, working with the Joe's department and the county health district, working with Judge Doherty, all of our providers, our schools, all the different partners. I'm really impressed. Our board members, I'm really impressed with the collaboration that goes on here. Joe mentioned for a year, I'm able to blame him. That's just preliminary. I think we can go and have that changed like any good legislation. But I want to say how wonderful it's been working with Joel Mallory just 2.5 weeks. And I think the Mental Health and Recovery Board is really strong here, and a lot of the recovery programs are really strong here, in part because of Joel's really fantastic leadership. We're going to have him for about 2 more months or so, but I think we should start thanking and celebrating him now, because he won't be here next year for next year's conference. He's moving to Montana. It starts snowing there around Labor Day, so I don't think he's gonna get back, but I just really want to say how much I appreciate Joel's work and what a great job he's done with the Mental Health and Recovery Board. And if everybody could just give him a round of applause. I won't go on forever. I hope you enjoy the conference and find it useful. I know I really have, and have been really impressed with the speakers. And one of our staff members who you all know, Karen Kravitz, has been instrumental in putting this conference together, so we really appreciate all of her work on it. And I think I'll turn it back to Joel and the panel. I really look forward to working with everyone. Thank you.
I'm going to keep people moving along. So it looks like the first one is Renee Clarick, University Hospitals. About an update.
Good afternoon. Just a few updates from a hospital perspective. You know, University Hospitals is a very large hospital system. We have about approximately 25,000 employees in Northeast Ohio. And one of the things that I've heard repeatedly today is a lot of you became addicted through legitimate prescription medicine. And that's something that the hospital has addressed this year, along with the Cleveland Clinic as an consortium. We have come together to develop an institute that we restrict the amount of medication that's given to patients on an ongoing basis, whether it's surgery. It used to be when you got hurt, like you were saying, you got a ton of prescriptions for pain medications. We are not doing that anymore. For a long time, we thought that was the best way to treat people, and now we're finding out maybe that's not the best way to treat people. So overall, the hospital has reduced its morphine equivalent drug issuance by over, I think it was like a million and some odd number that they gave. That was amazing. So we reduced it considerably, about 70% of what we were doing before, which is a really good thing across the board. Here in Portage County, we had, along with Joel, where's Joel? Joel, I want to bring up, what Joel managed to do is we have a $250,000 grant at Portage County for our medication stabilization service, which we're doing withdrawal in the hospital. Many of the drugs that people are withdrawing from are incredibly dangerous. We don't even know what half of them are. So people will start one withdrawal and then go into another withdrawal, and stabilizing them has become a very complicated issue. So it's very dangerous, but Joel has gotten the $250,000 grant that we could treat patients at the hospital for this withdrawal, which is spectacular. Thank you, Joel. It's a great gift for Portage County. In addition to that, we work with Coleman Services. We actually work with all the agencies. We work with everyone. What we want to do is integrate all of us together to have healthcare and behavioral health, an integrated system. So we have another grant with Coleman Services where we put someone in our Portage County ED to help people who are coming in who are overdosed or had mental health issues that typically before, as typical hospitals do, they treat and they release and say, okay, go away. Well, we're not doing that anymore. We're making referrals to our addiction services, and we're making referrals to Coleman, and to have warm handoffs from both sides, which is very, very important. The other thing we're doing is working with peer supports, and through the grants that Town Hall 2 and Coleman and other places have peer supports. When we have someone in the hospital that has no way to get to the doctor, doesn't know what they're doing with addiction, they end up there because they have infections or they have endocarditis, which is a very real thing and very scary thing. So our peer supports, we introduce them to the patient while they're in the room, and then we link services afterwards. So it's a seamless handoff. Our whole goal is to navigate and facilitate everybody here working together for the good of the patient. And that's really become the goal of our medical assisted treatment program. We're more of a service, not a program, because people call us, they want information, we navigate you. The behavioral health industry is very complicated. If you're not in it, nobody knows what an IOP is. What's an IOP? What's a PhD? What do all these letters mean? And so what we try to do is explain that to them, find the level of need that they have, and send them in the right direction. Some people need withdrawal, some people need stabilization, some people need residential programming. It's whatever that patient needs. So we want to be a source of information for all the patients that call in. Lastly, we're changing the mindset of physicians. For a long time, we've called this an acute disease. It's not an acute disease, this is a chronic disease. Once you have it, you have it. And you have to learn to manage it for life. And if you hear any message from me, that's my overarching message. It doesn't go away once you have it. Learn to manage it, and that's what we're all here to teach you. You will manage it the rest of your life, or it will manage your life. So it's no different than diabetes. When people have diabetes, we say, I'm sorry, you now have diabetes, you have to manage this disease the rest of your life. And unfortunately, this falls into the same category of chronic disease management. And I know that's a lot, but to know that you can manage it is the key. And that's what all the people that we're talking here today, they are teaching you, you can manage this disease if you want to. And with that, thank you.
Thanks, Renee. Bill Russell from Coleman.
We let Renee go first so she can show us all up. Send the bar behind to start. I'm Bill Russell, Chief Officer of our Portage County and Coleman offices here. Karen and Jill asked me to talk a little bit about general updates on our Behavioral Health Navigator program in partnership with which Renee mentioned. So to date, we started running in June, started tracking some results. Quarter one this year to date, so July, August, September, we've actually seen 102 people already in the ED. Our navigator is a social worker in Joel, not to be mistaken, it's Joel. We're there to provide some assistance and expert evaluation and brief screening and pre-screening assistance to the medical staff in the ED. We are finding there's an increasing trend and focus on population health management, getting people out of acute stabilization, transitioning into their outpatient care program. And we're finding that the navigator position is really closing a gap in this care and helping economize service usage within the medical system. Basically, that means you don't have to we're trying to cut down the ED wait times. We're trying to get people in and out in, let's say an hour versus having to sit and wait 16 hours, that kind of thing, to get to the place where you need to go. The next step, we haven't fully hit on this yet, but we're starting to track attendance and follow through with recommended care. To date, we're showing about a 60% success rate. Follow up with first and second appointment post-acute care in the ED, post-assessment in the ED. I think that's probably the most exciting thing I got to share in regards to this program. So with that, I'll take it back to Joel.
Thanks, Bill. I have two people from Town Hall 2, Rob Young and Bridget Stuntz, so I'm not sure who's going first, but Rob?
Appreciate the opportunity to share a little bit about something that is near and dear to my heart, and that is Portage County finally making productive use of what are peer supporters, or the correct term being peer recovery supporters. For the sake of time, just a quick overview. Basically, two unique characteristics that peer supporters have. Number one, they are equal to the client. They're called peer supporters. The other important piece is that they are very open about their recovery status. And this can be recovery from addiction or from mental illness or from both. And they use this openness and this peer relationship to assist others by sharing their personal journeys and their knowledge and expertise. And this is fairly unique, certainly for professional helpers, because one of the first things they teach in a counseling class is self-disclosure is not a good idea. You can do it, it can have some therapeutic value, but in general, as clinicians, you're not supposed to self-disclose. But peer supporters are absolutely going to do that. That's what makes them special and unique. So they can provide a number of different roles. They can certainly be a motivator and cheerleader. We've heard that through Judge Doherty's drug court with Matt, and certainly Bill talking about Joel there at the hospital. He can certainly serve as a role model and mentor. Confidant and supporter. Peer supporters have the unique ability to listen and to empathize with the pain and struggles that the person's going through. And they can also be very supportive in terms of, hey, let's take you to a meeting. I will join you in court for your hearing, take you to a medical appointment, things like that. They function as problem solvers, and they are resource brokers. That's a big part of what their job is. They can, again, sign them up for Medicaid, get them a Social Security card, birth certificate, ID, food card, bus tokens, teach them how to read a bus schedule. I mean, these are important things that are going to help the person perhaps get involved in services, or more importantly, stay involved in services. Now, for the last couple of years, the state of Ohio has a mechanism in place to train and to certify peer supporters. First thing you need to do is simply acknowledge that you are a person in long-term recovery. Again, this can be from mental illness, addiction, or both. You must provide 2 personal references, and you must complete 40 hours of in-person training. So this is nothing that, yeah, I guess I'm going to be a peer supporter today. This is a significant commitment that these individuals take on to become a peer supporter. And if that 40 hours wasn't enough, they are also required to do 16 additional hours of what's called E-Based Academy. That's online training and learning, and supervisors have to do that as well. You better pass your test, and you also have to pass a background check. There are some offenses that make you ineligible to become a peer supporter. So again, that's peer support in a nutshell. Currently in Portage County, we have 9 or 10 peer supporters. That number may not be totally accurate, but of that 9 or 10, we have 5 who are working collaboratively on the Recovery Outreach and Support project, which I'm very, very, very excited about as well. And Bridget will talk more about that. Jay, thank you.
Hello, my name is Bridget. I'm a grateful recovery pickle. Actually, I'm a recovering addict and alcoholic. I'm also a peer supporter that Rob was just talking about. Yeah, we have about 9 or 10 peer supporters that I know of in Portage County. And some of what we actually do, we do in-reach services into the jail. We do outpatient services at our providers. We do residential treatment services at Horizon House, Root House, Park, Rehab. We go into the court. I know I sat in Judge Doherty's court, actually several times a month, I would say. We have a peer supporter that is working with JFS, and now we have a new peer supporter there that does probation and at drug court. So we have a new recovery outreach team, and has anyone heard of quick response teams from like Summit County? Okay, so we're modeling this similar to those quick response teams. What our recovery outreach team is, basically we're going to visit a residence after it's had a 911 call. It doesn't necessarily have to be an overdose like Summit County's quick response team, just somebody struggling with addiction, or if a family member has asked for help, or if a person themselves has asked for help after a 911 call. So we have a team of 5 peer recovery supporters. Right now, they're working under a grant funded by the Mental Health Recovery Board and this grant. And we're trying to go out within a week after this 911 call. Right now, we have 3 communities that we're piloting, which is Aurora, Brimfield, and Streetsboro. And we're just kind of setting it up with each of these communities that best fits the need of the community. Right now, like Streetsboro has a fireman that's going to go with a peer recovery supporter. Brimfield and Aurora each have a policeman that are going to be able to go out with this team. We're just going to have like 1 or 2 of us peer supporters go out with the policeman or the EMT fireman on these calls. As some of the prepare for some of this, the peer recovery supporters went to Barberton to kind of shadow, get an idea as to what worked for them, what did not work for them. And we reviewed some of our own detox protocol, how that would work, so that we're ready to go, when we knock on the door, what is it that we're going to do? So, it's taken a while to work out some of these kinks and really prepare ourselves. We've actually been on 2 calls. So wait, let me back up. When we go on the call, we first get a referral from the community, and then the police will check and make sure that there are no open warrants on the individual where we're going, and also make sure they don't have any violent offenses. We need to make sure what we're walking into. And also, the police, if we're going with an EMS or fire, the police need to know where we're going to be going. We want to make sure that we're going to be safe when we go out there. So we're going to go to their home, we're going to knock on the door. If someone's there, we're going to let them know you're not in trouble. This is just a follow-up to the 911 incident, which is public record. We have an EMS or fire with us, or a policeman with us, and just offer them referral services. We're going to take the beautiful addiction resource guide the Mental Health Recovery Board put out. We have meeting information, NA, AA, Al-Anon meeting information. If they're not home, we have these packets, we put together all this information. We're going to leave them a sorry we missed you letter with their name on it, and maybe just their first name, not put the last name on there. But anyway, and then if they are home, we're going to offer them the information of detox. Ask them if they want detox, what kind of services they need. We're all trained in giving them all kinds of referral, community information, that type of thing. So we have had 2 calls, 2 referrals. One was in Brimfield. We went out there with the police officer who was working with us. We went out to this beautiful home. Nobody was home. It was kind of apparent that it might not have been the place of residence. Even though she gave this as a residence, we kind of knew she wouldn't be living there at this particular time, but nobody was home. We left this on the door with the "sorry we missed you" letter, and I got a call back the following Monday, and the woman thanked us for coming and providing the information. She said that she would let the individual know. She hadn't talked to her, it was a family friend. She hadn't talked to her in a while, but she was very thankful that we gave these resources out to her. She said she would let her know, that she talked to her. And then we had another referral from Streetsboro that part of our team went out to last week, and they actually met. It wasn't the individual themselves, it was the mom who was taking care of the individual's kids. So it was a lot of family support type of thing. She was already involved in Pullman services, so our peer supporter from Pullman kind of took initiative on that particular visit and just offered her services, let her know about Al-Anon, let her know what community partnerships we have, and you know, offered her support, the things coming up for Christmas to help with the kids and help just provide this woman with support. I mean, here she was stuck with her grandkids. The individual had run off into somewhere in Cuyahoga County, didn't really know, she was ripping and running, you know. So just kind of really let them know that we're here and we're available and where she could call. You know, that we have 678 HELP, the Pullman Access Line, you know, just try to let people know that we're here for them. So I didn't follow the script at all, but I think I'm done.
I do want to mention, I can't get my slides to work, but we had a prevention speaker this morning, and we have both our board and the commissioners support from Town Hall 2, the Too Good for Drugs and Violence Project Award. These are basically programs that he even mentioned are good prevention programs in schools. And the commissioners are also putting some money toward that. Also, the commissioners, along with the mental health board, are helping to support both interventions in the schools. Some of them are mental health therapists in the schools that primarily we as the board support. And the commissioners recently added 6 case managers across all 12 school districts throughout the county to assist in linking up families to services. So, speaking of Town Hall 2, we move on to Children's Advantage and Nicole Thomas.
Hi everyone, I'm Nicole Thomas. I'm the Director of Program Development and Trauma Services at Children's Advantage. And what I want to update us on, first off, I want to say it's such a blessing to be in the room with all of these people because you guys are making such an impact in this community. And where I'm coming from is the impact that I see to children and families. You know, when I first started doing trauma work at Children's Advantage, it was just me. I was the only certified trauma practitioner. And unfortunately, over the years, as the opiate epidemic has just plagued our county, it's definitely impacted the children and families of this community. I am happy to say, and with the support from the Recovery Board and also United Way, we're able to do more with trauma services. Now we have myself, Brian Pavelko, Danny Casterline, who are certified trauma practitioners. They see kiddos on the individual outpatient level and also do family therapy. But we're also able to train intensive in-home providers as well. So we have 3 intensive in-home clinicians who are pursuing training in trauma therapy. They'll be certified trauma practitioners. But I think the biggest thing that I'm here to say is that I think that the impact that this has had on children, the trauma and traumatic experiences and events that they've had to witness, has really been eye-opening over the last several years in my work. Just how much we're not quite there yet. We're not done yet. We're offering a variety of different services. We do a lot of different evidence-based practices, EMDR, SITCAP, TSCPT, which are all a bunch of acronyms that some people here know and some people don't. But what matters most is that what we're seeing is we're starting to see healing. And the way that we see healing is the community coming together and all of these entities, all these agencies, these organizations, nonprofits pulling together to offer comprehensive services, different types of outcome approaches. And what we're doing at Children's Advantage is we're walking with our families to be able to see them heal. And that journey is a long journey. It's taking a lot of time, a lot of manpower, a lot of patience. And it's just so rewarding to be able to see it, but we're just not there yet. The other thing that I do want to mention is the prevention case managers that Joel's talking about has really just been wonderful to be able to offer that in the school system. So with our 6 new prevention case managers, we're able to offer more extensive services. We're able to link them with outpatient counseling, family therapy, but we're able to offer those services right in the schools. To date, we've served 254 students this year with the ability to offer the prevention case management. So with that being said, I think the other, my goal is to continue to educate and provide trauma-informed care in this community. I go to schools, I talk to law enforcement, really I talk to anybody who will listen, about trauma-informed care and how we all need to understand that the impacts of trauma is really where this all starts. A lot of people that are in recovery, we're trying to medicate and try to heal from their own trauma on their own, and they need a little extra help. So what my goal is, I hope I'm out of business one day, because we know how to heal trauma very early on. And I think that we can do that. I think that this is the right group of people to do so. So thanks.
Mr. Cole. And now we have Kelly Jo Jeffries, Director of Job and Family Services in Portage County.
My name is Kelly Jo Jeffries, and I'm the Director of Job and Family Services. And we are a quadruple combined agency, and substance abuse has impacted all 4 of our divisions. We have child support, we have workforce, public welfare, and most significantly, it's impacted our child welfare system. So to start, I just want to give you some, I'm not going to go on a long speech, but some sad but striking statistics about the impacts to our system. Currently, we have 241 children in foster care at Portage County, in Portage County custody, and that's about 80 children more than we had 2 years ago. One of the speakers earlier said, statistic-wise, we have about 65 to 70% of those cases, the parents are impacted by a substance abuse. What we're seeing now is half of the kids in care are less than 5 years old. And we have teenagers that are emancipating or graduating or growing up in foster care. So they leave us at 18 and go on to adulthood. And that's a stark reality. Our placement costs are significantly high because a lot of people don't want teenagers in foster homes. So we see we have 25 youth around the state of Ohio that are in residential treatment centers. So that's a startling reality for us. And child care expenses are very high for child welfare because if you have half of your kids under the age of 5, they need to be in services during the day. We have 200 employees at the agency, and 20 of my staff are here today. And that's a testament to, despite the fact that they deal with on a day-to-day basis crisis and trauma for the kids and the adults on their caseloads, they're here to show support for the community and what's happening in the community. One lady said it's a blessing to look out in the audience to see all of you here. We're very happy that the Mental Health and Recovery Board received some increased funding for services, because without services, we wouldn't be able to work with our families. Unfortunately, Ohio is 50th in the nation on the bottom end of the spectrum for child welfare funding. So despite the fact that we have more kids in care than ever before, our system hasn't seen an increase in funding at all. So again, we rely on the services of this body here on the stage to help us out with treatment and recovery. Also relevant to that, and just a little plug about the Affordable Care Act, which is better known as Medicaid. Without Medicaid, we wouldn't have the insurance available to be able to get a lot of these treatments and services. So I wanted to make sure I put a plug in for the Affordable Care Act. So it's not all gray and dismal at Portage County, although our statistics are startling. We are very proactive in trying to reunify families. Unfortunately for us, statute really only gives us a 2-year window in which to reunify kids with families. So our work has to be tedious and fast and focused on reunification. So the judge spoke earlier, and I'm not going to get into my position on one, but without the partnerships of the court and law enforcement and the mental health services, we would not be able to be as successful as we are. Sometimes incarceration for some of our parents is the difference between life and death. And so, again, I just wanted to put a plug there. Relevant to what's happening in our system, we have a very vibrant independent living program. So we really strive to give our children the experience of what normalcy looks like. They crave to be home with their parents. They are the parents' biggest cheerleaders in this endeavor. They ask frequently when they can go home. Just last week, we had a staffing where we had a mother who was in recovery for 1 year, and unfortunately, she relapsed. Her child was at a place of having unsupervised visits, and as a result of that, we had to go back to square one. Square one only gives us one year left to be able to try to accomplish the goal to reunify, or statute recommends that children go into permanent custody or ultimately be adopted by somebody else. So this issue is such a grave issue, and these providers are such a valuable aspect of our community. That's why when you see all these levies coming up, they're vital, and you need to support them. I'm going to put a plug in for our levy in 2019 since I'm up here. We have a child welfare levy coming up, and without levy funding, we could not continue to care for the children, the 241 children in care that we have. So one good new program that we're looking at, and I'll end there, is through a collaborative approach between the Mental Health Board, a community partner agency, and Children's Services. We're looking at co-sponsoring a recovery home for families. So we know relapse on average is 5 to 6 times. We like to see parents sober about 6 months before we start to target recovery. We think we can try to reunify families sooner. If in this approach we place children back with their families in this recovery home system where there's support available, where social workers can drop in on a daily basis, it brings the kids and their parents closer together. It ultimately takes kids out of foster care sooner. And it also helps our bottom line. So that's something we're going to pilot in the near future. We hope the community supports that. On behalf of Job and Family Services, I want to thank all of you as providers for the work that you do. Thank you.
One more person, Larry Limbert. I'm going to remind Larry, first of all, his boss is in the back there, Sheriff David Doe. And secondly, we have just a few minutes, so you got to talk fast there. I know you're a little long-winded sometimes, very passionate.
The sheriff has a tendency to follow me around to make sure I'm politically correct, because I really have a problem with that sometimes. I represent the Portage County Drug Task Force in the county. The Drug Task Force is a multi-agency entity that is headed by the sheriff's office. The sheriff is responsible for the daily operation of the task force. The task force is made up of a lot of different agencies throughout the county. Streetsboro, Aurora, Kent, Ravenna Police Departments, along with the sheriff's office, all participate in the task force. And when we talk about participation, we're talking about personnel that have been assigned from their agency to work solely on narcotic investigations throughout the county. So these guys are assigned to the task force, and that's their only assignment. In addition to that, we've brought on board, we've got 3 DEA agents that work out of our office. We have an FBI agent that works out of our office, and a Homeland Security agent that's there also. So we've got a large variety of law enforcement agencies come together as one to try to combat the problem. I'm going to ask a question because I ask it every place I go whenever I talk to a group. How many of you think we have a heroin problem in this county? Okay, you all fail. And here's why I say that, because everybody says, you know, why aren't you guys working, why aren't you trying to resolve the heroin problem in the county? Why aren't you doing something to resolve the heroin problem in the county? One of the things that we have to do is on a daily basis, we have to report to the state of Ohio the drug seizures that take place within our county. And when we sit there and look geographically at the county and look at the drug seizures that we see, again, we're looking at all 88 counties in the state. Right off the bat, we're number 3. Portage County is number 3 in the state of Ohio for cocaine seizures, which is just kind of up there. And I don't know if we're glad to see it back, but it certainly beat the heroin that we were seeing for a long time. We're number 2 in the state of Ohio in crack cocaine seizures. So again, cocaine and crack cocaine has really become really a problem for us here. Fentanyl, we're like number 11 in the state for seizures on fentanyl. And then our biggest problem that we're seeing that we've made the largest seizures on so far have been for methamphetamine. And we're number 2 in the state of Ohio. And we keep getting beat out every year, the last couple of years, on the methamphetamine by our partners over in Summit County. So, when we look at this drug problem, we're looking at drugs that are not only in the county, but they're coming into the county from all the surrounding areas throughout the state and even nationally. We also, sit back and look at, not only the street level violators in the county, but where's our supplies coming from, which takes a lot of time and effort. I spent some time in Columbus last year with some other drug investigators, and everybody was talking about the overdoses, and what an increase we had in overdose. And I'm looking at the numbers that we had in Portage County, and I felt really good because our numbers were really low in overdose deaths compared to anybody else in the state of Ohio. And as I was driving back from Columbus, reality set in, and I said, you know what, we're looking at the numbers of people who have actually died and their death has been reported in Portage County. We're not looking at the number of Portage County residents that have left Portage County and went to Cleveland, went to Akron, went to Warren, went to Youngstown, and got their drugs there, used them there, and died there. So the problem is more significant than what sometimes was really reported. But that's really all I have for right now, and we're just going to keep pounding away at it and see what we can, see if we can make a bigger impact. Thank you.
Who's handling the questions? I guess we have a few minutes for a half a question. Becky, Karen, because we also do have another recovery story.
I'm going to go and make you read the questions.
Take the glasses now. Okay, what are the possibilities of using medical marijuana for MAT, medication-assisted treatment programs, possibly instead of Suboxone, methadone? Renee, Bill?
I think so. I've heard a lot of times people say, well, you're exchanging a drug for a drug. We're exchanging a drug for a medication in Suboxone. It's a controlled medication. Marijuana, there's Marinol, there are drugs that are taken out of marijuana that are medications. Marijuana itself is not a medication, it is a drug. And that's why they're releasing it for recreational use. Make no doubt about it, marijuana is a gateway drug. Marijuana leads to further addiction. And to say we want to treat a drug for a drug, a street drug, is insane. So let's talk about medication, let's talk about medical issuance of a drug. So is everybody familiar with Marinol? Everybody know what Marinol is? Well, they've come out with, I think it's a TCB for the children now. The 2 drugs that they wanted to legalize marijuana for are now in pharmaceutical grade form. The rest is just smoking marijuana, make no doubt about it. So if they want to use the medication that they extracted from marijuana to treat MAT sometime in the future when they're doing research, and they found it's effective, that's one thing. But to smoke marijuana for stopping to use heroin is unheard of.
Okay. The second question here is, As we hear in recovery stories, people with addictions do a lot of things that they never thought they would do. Can you explain scientifically what happens to the brain in an addict as progression takes place, and why they cannot accurately make a rational decision? Why can't somebody just stop? Rob?
Still my thunder for tomorrow night. I'll try to keep this as short as possible. The disease of addiction affects pleasure and reward centers of the brain. Basically, what's going on is the buzz feels better than it's supposed to. And as a result, the brain places an extraordinarily high level of importance to that buzz or to that effect. And it starts to creep up there as being just as important as perhaps food and intimate behaviors or sex. And so the brain has already decided, oh, this is extraordinarily important to use this substance because it feels so remarkably good. That, coupled with the fact that the decision-making part of your brain, that prefrontal cortex, begins to be distorted, begins to be impaired, again, because of that abusive use. I often use the example of a person who plays golf. You shoot around to 50, that means, you really didn't do that great, at least for me. But you keep going back because you remember the 3, 4, 5 amazing shots that you had during your round of 9 holes. You forget about, slicing into the woods and, this is a 2-foot putt and things like that. Because the reward of those amazing shots takes on a greater importance perhaps than logically it should. So I hope that answered it to some degree, but again, that the brain has placed way too much importance because the buzz feels way better than it's supposed to, and then that decision-making part of the brain is not working the way it's supposed to as well.
Thanks, Rob. The other question I had here, actually, I think Larry addressed it, but I'll see, Larry, one more shot here. It says, what are the most current opiate and non-opiate drug trends, probably in Portage County? Anything else you want to add to what you said?
Well, like I said, we're not really seeing a lot in the pharmaceutical side of it right now because we don't concentrate that much on the pharmaceutical side. When we look at the heroin, heroin is so far down on our scale right now, it's unbelievable because we're probably about 58 to 60 on the scale throughout the county on seizures from heroin. But right now, like I said, the fentanyl is getting intermixed with cocaine, with the methamphetamine, and therefore, we're still seeing a real problem with overdoses because of the fentanyl and the carfentanil.